What an astounding, you guys have no idea how lucky you are to have this group of guys up here. Thank you guys for coming to Florida and helping out. All right, we'll start with questions from the audience. Jason, we'll start with you, and everyone else can answer. Do you decrease opioids before a trial for spinal cord stimulation or intrathecal medications?
Yes. Yeah, so there was a study that was done looking at longevity of spinal cord stimulation, and definition of that was having retained the implant at greater than a year. And so when you looked at that data retrospectively, and it's published in the journal Neuromodulation, if people were introduced to spinal cord stimulation, if they had been weaned to 90 morphine equivalents or less, they had a higher likelihood of retaining their therapy at a year. So the thought is to at least get people down to the 90 morphine equivalents. And then during the trial, I usually communicate with patients by saying that these are typically as-needed medicines. So if you don't need them, don't take them, understanding that if they're on a dose that could precipitate a withdrawal, if they just stop the medicine, that we encourage kind of a slow wean. Most spinal cord stimulation trials in the United States are 3 to 5 days, and with some of these advanced therapies, they're sometimes 7 to 10, but oftentimes patients will auto-titrate, which is one of the endpoints that we follow when we have them come back. So we push people a Promise 29, we give them an opioid survey, and we look at activities throughout the trial, and we see them back post-operative day 1, 3, 5, and 7, and obviously if we take the device out, the trial is over. For intrathecal therapy, I do very much the same thing, and there's a lot of data to describe that when you use intrathecal therapy and you're offering those bolus strategies and the PT, or I would say the patient therapy bolus strategy, that it reduces the need for systemic opiates. And there's a lot of data on that. So, but I do try to wean people down to the 90 morphine equivalents, and in my practice, we don't prescribe above that. So that's kind of the prerequisite to kind of enter into the practice in the first place.
Peter, do you want to comment?
Well, I think Jason's entirely right. I think when we started this, we thought about this as different routes of administration, and for intrathecal therapy, we would, a lot of us would start with just adding in intrathecal to systemic medicines, and that was an utter failure. I think what we've learned over time is less is more, and that if we can titrate people down or preferably off of the systemic opioids, not always possible with some of the cancer patients and other complex patients, but as much as you can titrate them down, the outcomes are better. And one could have originally posited that, well, these are sicker population if you can't titrate them down. Having said that, objectively, when we do take people down, that population seems to get more better. And I think it's also true with stimulation as well. I think if people come in on exceedingly high doses of opioids and you just keep them there, their outcomes are poor. So I'm in agreement with the gentleman from California.
It's interesting, Jason, that in your approach, rather than the patient coming in, you just talk about putting in a trial, you actually have to take some time to get to that stage. And so that may take weeks or months to get them down to that below 90 morphine equivalents. And it is a more of a long-term look at this patient rather than the short-term, let's get you in the trial next week.
And it's a lot harder to actually talk to a patient and explain to them what will be not intuitive to them, that we're going to take you off your medicine so we can get you feeling better. It's not intuitive, but when you take the time with people and they're willing to be compliant with you, they can do very well with that strategy. But as you say, it takes time.
Yeah, it's funny. I always use the analogy. I said this is not a sprint; this is a marathon. And I know that you're concerned about your pain this week and this month, but I have to worry about your pain for 10 years from now. And so, in taking that slow approach and looking at that patient is really key. That's great. Anyone else? Okay. Next question here. Thank you. This is an easy one. Okay. When converting from morphine to hydromorphone intrathecally, how do you convert dosing? Anybody want to take that one?
So usually if you're on like 2 milligrams of, I'm very conservative. So first off, you know, when I do my trials with intrathecal opiates, I work in an outpatient center, and so I do send patients home. And we usually will observe them 6 hours before we remove them from observation. So for my intrathecal trials, I'll give someone a 0.25 milligram dose of morphine. And when you look at the data on respiratory depression in the purulent population or in people that had transurethral resection of prostate, there are tens of thousands of patients that have been exposed to intrathecal opiates there, and the chance of respiratory depression as defined as a PaCO2 of more than 45 and a respiratory rate of less than 12 is very, very low. So that's the thought associated with giving them a 0.25 milligram dose of morphine. And then I give people a 0.04 milligram dose of Dilaudid as a trial, or a 25 microgram dose of fentanyl. And so that's my approach when I do intrathecal bolus trialing. And because I implement my therapies the same way that I trial, I give them a single bolus over a 24-hour period, mirroring the trial experience with titration up about once a week.
So that's great. That's correct. I think one of the nuances of this is typically people refer to it as a 6-to-1 conversion or a 5-to-1 conversion of Dilaudid to morphine. That probably holds at the very low doses, but if you're converting patients over at at higher doses, significantly higher doses, those conversion tables that you'll read about don't work. So you have to be even more conservative. So if you're going to make a conversion from morphine to hydromorphone, you might say, okay, that's a 1 to a 0.2 or something to that effect. But you really do want to be conservative in your estimates, understanding the any kind of error in the catheter volume, et cetera. You really want to make sure that you are probably cut back on that typical conversion at the lower dose significantly, and then you can always go up. At the higher doses, you even need to be more conservative. And I typically will titrate people down before I'll make a switch if they're on higher doses of opioids intrathecally.
I do the same thing. I go the 5-to-1, but I don't use it. So if it is 0.2 to 5, I will to 1, I would probably go to 0.1 and bring my patient often to start titrating it up. As long as the patient doesn't have any withdrawal symptoms, you can always catch up with the patient. So the last thing I want to be is going by a book that does not have this. Most of these conversion tables are done with healthy volunteers, not with patients on chronic opioid therapy. So it's important that we are careful. That will be my only suggestion. It's a very simple rule for me.
Yeah. And I think the point is well taken about higher dose opiates in the intrathecal space. As part of my practice, I try to avoid that, especially with the more recent literature coming out. So as a general rule, I use the 5-to-1 ratio and just avoid high-dose opiates.
Okay, thank you. Nagy, this one's for you. This is a good question, actually. What's the value of an RCT trial versus a retrospective real-life study?
There are advantages and disadvantages of both. The retrospective is much cheaper and you can do it wherever you want, and you can predict the results before you start. Randomized controlled trial, especially if you have blinded element, is much more robust to give you a good answer. And the idea of the clinical research is to focus on one question and try to standardize all the